Hello and good afternoon, dear students. My name is Dr. Zabiullah and I will be guiding you through the endocrine system from USMLE Step to CK. Today we will discuss one of the most important topic, SIADH, mean Syndrome Inappropriate Antidiuretic Hormone, and Diabetes Insipidus. Diabetes Insipidus. Before going into detail of SIADH and Diabetes Insipidus, we should know about the normal production of antidiuretic hormone and mechanism of action of antidiuretic hormone. So first of all, we will discuss about the normal production of antidiuretic hormone and its mechanism. Guys, just imagine that this is a hypothalamus, this one is the anterior pituitary, this one is the posterior pituitary, and this one is a hypothalamus. In hypothalamus, two important nuclei are present. The name of the one nuclei is a paraventricular nuclei and the name of other nuclei is a supraoptic nuclei. From paraventricular nuclei and supraoptic nuclei, paraventricular nuclei play an important role in the production of antidiuretic hormone into the hypothalamus. And from hypothalamus, this antidiuretic hormone will come into the posterior pituitary. In posterior pituitary, the antidiuretic hormone, it will store here and it will release when our body will need. So if someone asks you a question that antidiuretic hormone is produced with the help of which nuclei, you will give the answer that specific one is a paraventricular nuclei. But in some books there is also written that with the help of paraventricular nuclei and supraoptic nuclei. If there is mention about both nuclei, you have to click upon the option of paraventricular nuclei because this is asked many times in the exam. Number one. Number two, guys, and if someone asks you that where antidiuretic hormone is stored and released, store and release, then you have to give the answer that antidiuretic hormone is stored and released into the posterior pituitary, Guys, you know that this one is a hypothalamus. Here is a hypothalamus, here is a posterior pituitary, okay, here is a anterior pituitary, and this hormone basically come from hypothalamus into the posterior pituitary. So something will bring from the hypothalamus into the posterior pituitary. This is also important thing you have to remember. You have to give the answer that basically a protein, there is a carrier protein which brings antidiuretic hormone from hypothalamus to the posterior pituitary. So how many points you have to remember? 3 points. Number one, antidiuretic hormone is produced with the help of which nuclei? Paraventricular nuclei. Antidiuretic hormone produced from where? Hypothalamus. Antidiuretic hormone store and release where? Posterior pituitary. With the help of which protein antidiuretic hormone comes from the hypothalamus to the posterior pituitary? We will say the name of the protein is the hypophysial carrier protein. So it was a little introduction about antidiuretic hormone. Now examiner asked many times in the exam that tell the name of hormone which maintain serum osmolality, The right answer is antidiuretic hormone. So you have to give the answer. The right option is the antidiuretic hormone. Now we will discuss about the mechanism of action of antidiuretic hormone. Guys, why I am going to discuss about the mechanism of action of antidiuretic hormone? If someone don't know about the mechanism, then how the guy will understand about the medicine? Simple. So we have to understand that what is the mechanism of antidiuretic hormone. Guys, antidiuretic hormone basically act on two type of the receptor. The name of the one receptor is the V1 receptors and name of the two other receptors is the V2 receptors. V1 receptors are basically present on your blood vessels and antidiuretic hormones comes on the blood vessels. Just take an example that this is one is a normal blood vessel. When antidiuretic hormones will come on the blood vessel and it will act on the V1 receptors. After acting on the V1 receptor, it causes the vasoconstriction or vasopression. When the blood vessel will be pressed, then what will happen? The lumen will be decreased. You know that here is a normal lumen, here is a normal lumen, and what happen here? Here the size of the lumen is decreased. When the lumen will decrease, then what will happen? Total peripheral resistance will increase. When total peripheral resistance will increase, it's mean that your diastolic blood pressure will increase. This is very basic thing. I hope so everyone understand this one. And on the other side, when antidiuretic hormone will act on the V2 receptors, we have to understand that where the V2 receptors are present. Guys, basically I hope so that this one is a nephron, in the nephron, and this one is the collecting tubules. Just take an example that this one is a collecting tubules. In the collecting tubules, basically in the collecting tubules, basically you have to give the answer that there is present of the principal cells. Which cells? Principal cells. And in the principal cells, these are the principal cells. In the principal cells, there is the V2 receptors are present. Which receptors? V2 receptors are present. Antidiuretic hormone will come, act on the V2 receptor. When the antidiuretic hormone will come on the collecting tubule on the V2 receptors, when the V2 receptors will be activated, after the activation of the V2 receptor, there is presence of aquaporin channels on the collecting tubules. These aquaporin channels will open. When the aquaporin channel will be open, then only water will be reabsorbed from kidney tubules, and where it will go? Here is blood vessel. It will go into the blood vessel. When the fluid is going from the kidney tubules into the blood vessel, guys, then what is going to happen? The fluid will not come in the maximum amount into the urine. Then the fluid, where is it is going? It is going into the blood. When the fluid will go into the blood, it can lead to the hypervolemia. It can lead to the hypertension, and it basically cause the low urine volume. When the urine volume will be decreased, it can cause the concentrated urine. So I hope so everyone who's listening me understand that antidiuretic hormone basically act on the V2 receptors on the kidney tubules. After acting the V2 receptors on the kidney tubule, it basically open the aquaporin channels. When the aquaporin channels will be open, then the water will be reabsorbed. Only water will be reabsorbed from the kidney tubules, and where it will go into the blood. When it will go into the blood, it can lead to the hypervolemia, hypertension. Number 2, very small amount of the fluid will go into the urine. So which type of the urine is known as a concentrated urine. Other than that, it also act on the V2 receptors. When it will act on the V1 receptors, it will act on the V1 receptors which are present on the blood vessel. It causes the vasoconstriction or the vasopression, and when the vessel will be pressed, it can lead to the increase of the total peripheral resistance, and your diastolic blood pressure will also increase. Other than that, guys, we also say that other name of the antidiuretic hormone is a vasopressive hormone. What is the other name of the antidiuretic hormone? Vasopressive hormone. What we have discussed? We have discussed some basic thing of antidiuretic hormone. We also have discussed about the mechanism of action of antidiuretic hormone. Now we will come to the most important topic of SIADH, syndrome inappropriate antidiuretic hormone, SIADH. Guys, SIADH, it is a condition in which antidiuretic hormone will release in a huge amount. SIADH will release in a huge amount, and everyone at least now understand that what is the mechanism of action. When antidiuretic hormone will release in an excess amount, then what will happen? Then from the kidney tubules, maximum fluid, where it will go? It will go into the blood vessel. When the maximum fluid will go into the blood vessel, then what is going to happen? Then it can lead to the hypervolemia, mean that the volume will be increased in this person. When the volume will be increased, then what is going to happen? Then the hypertension will see in this person. No, just guys take an example that we know a person that this is a normal solution. And in this solution, there is also present of the salt. There's also present of, for just taking a 4 liter of the fluid and 20 gram of the salt. Okay, and if in this solution only the water is coming, then what is going to happen? The salt concentration is decreasing or no? The salt concentration is decreasing. Same is going to happen in the case of the SIADH. In the patient of SIADH, the maximum concentration of antidiuretic hormone will be excreted. When the concentration of the antidiuretic hormone will release in excess amount, so the maximum fluid of the water will be reabsorbed from the kidney tubules, and where it will go? It will go into the blood. When the maximum fluid will go into the blood, it's mean that the sodium concentration will be the low. When the sodium concentration will be the low, it can lead to the hypotension hyponatremia. This is very important point, guys. One most important line which is written in every book when you read about the SIADH, that in a patient of SIADH, what you see, a euvolemic hyponatremia. Now we have to understand that what is the basically mechanism of action of a euvolemic hyponatremia. Why we see the euvolemic hyponatremia in a patient? At least we should know that what is the mechanism, what is the main cause of the euvolemic hyponatremia. We will discuss now, guys. You know that in the case of the SIADH, antidiuretic hormone will release in excess amount. When antidiuretic hormone will release in excess amount, then mean that maximum fluid will go where? It will go into the blood hypervolemia, mean that in the blood maximum fluid will go. When the maximum fluid will go into the blood in our body, when maximum fluid, when the fluid is high, then from our heart, from the ventricle, and also from the atria, two type of the hormone are released. One is the ANP and the name of other hormone is the BNP. Okay guys, when ANP and BNP will be the release, what ANP and BNP do? Just take an example that this is your kidney. In the kidney, the vessels which brings the blood toward the glomerulus are known as afferent arteriole, and the vessel which basically take away the blood from the glomerulus are known as the efferent arteriole. The two hormones ANP and BNP basically cause the vasodilation on the afferent arteriole. When the afferent arteriole will be dilated, it means that the maximum fluid will go toward the kidney. The maximum fluid will go toward the kidney, number one. And on the other side, ANP and BNP cause the constriction of the efferent arteriole. When the constriction on the efferent arteriole will be happen, so the fluid will return back. When the fluid will return back, then ANP and BNP basically cause the filtration of the fluid, mean that it can increase the glomerulus filtration rate. And when the glomerulus filtration rate will be the increase, it is known as the filtration. And after that, we all know that this fluid is also reabsorbed from the kidney tubules, from the proximal convoluted tubules. Maximum fluid is reabsorbed. Other than that, all the part of the tubules, the fluid is going to reabsorb. But ANP and BNP also inhibit the reabsorption of the fluid from the kidney tubules. When the reabsorption will be inhibited, then what will be happen? All this fluid will go where? It will go into urine. When all the fluid will go into the urine which was in a high concentration, now it is going to decrease. It is going into the normal condition. And when the fluid is going into the normal condition, this condition is known as a euvolemic. I hope so everyone understand about the mechanism of euvolemic, that why in a patient of SIADH there is mentioned or there is written in many books that a euvolemic hyponatremia. We have discussed about the euvolemic. Okay guys, that this is a mechanism of a euvolemic. Again, I'm going to repeat last time that first what is happened in a euvolemic antidiuretic hormone. First of all, SIADH antidiuretic hormone will release in excess amount. When antidiuretic hormone will release in excess amount, then what will happen? After that, we know that it will act on the V2 receptor. Aquaporin channels will be open. When aquaporin channel will be open, so the maximum fluid will go into the blood. Blood volume will be increased. When blood volume will be increased, it causes the hypervolemia. When hypervolemia will see one point, this one. When we see hypervolemia in any person, then at that time ANP and BNP basically release. These ANP and BNP, what they do, they basically cause the afferent arteriole dilation. When afferent arteriole dilation will be the C, so the maximum fluid will come toward the glomerulus of the kidney, and it can increase the glomerulus filtration rate. When glomerulus filtration rate will be the increase, so also ANP and BNP cause the inhibition of the reabsorption of the fluid. So what we will see, maximum of the diuresis will be the maximum. So when we will see the maximum fluid is going into the urine, so the fluid which was in a high concentration, it is going to come back into the normal concentration, and this condition is known as a euvolemic. Okay guys, now we will discuss about the hyponatremia, that why we see in a case in a patient of the SIADH hyponatremia. This is also very important point. First of all, We know in a case of SIADH, antidiuretic hormone release in an excess amount. When antidiuretic hormone will release in excess amount, so maximum of the fluid will go into your blood. When maximum fluid will go into the blood, it can lead to the bacho hypervolemia, meaning that volume will be increased. When volume will be increased, just take an example that this is a solution. In this solution, 4 liter is a fluid and 20 gram is a salt. And now take an example like this, that someone is putting the just a fluid in this one, water is putting in this solution. When the water will be just putting in this solution, what will happen to the salt? The salt concentration will be decreased. The same is going in the case of the SIADH, number 1. Number 2, guys, you have to understand, I hope so, everyone who's listening me must understand about this one, that in a patient of the hypervolemia, what we see hypertension. In case of the hypertension, RAS mechanism basically inhibited. RAS mechanism is not going to work. What's basically do the RAS mechanism? RAS mechanism basically cause the activation of angiotensin 2. Angiotensin 2 cause the activation of aldosterone, and aldosterone is a main important hormone which basically reabsorb the sodium into the blood. With the help of aldosterone, sodium will go into the blood, and potassium and H plus, where it will go? It will go into urine. Okay, guys. But now what is going to happen in a patient of SIADH? In a patient of SIADH, when already fluid is present into the maximum concentration into the patient, then it's mean that RAS mechanism is not going to active. When RAS mechanism is not going to active, then angiotensin 2 is not going to active. At that time, we will say aldosterone will be also inhibited. When aldosterone is not going to work, then the sodium will not go into the blood. Where the sodium will go? Sodium will go into urine. Okay, this is very, very important point. We will say that the sodium will go into the urine. And now we will say, what is the final hallmark of the SIADH? SIADH basically cause the maximum of the fluid will go into the, where the fluid will go? Maximum fluid will go into the blood. Fluid into blood. Okay, guys. And low fluid will go into urine. Okay, when the very low amount of the fluid will go toward the urine, so the urine will be concentrated or diluted? It will be concentrated. Here is also one of the most important point. What about the osmolality? We will discuss about the osmolality little bit later, but here we will discuss about the sodium level. We know in a patient of SIADH that sodium level, what will happen to the sodium level? In most of the patients, sodium level will be the normal. But if any patient present to us that the sodium level is not normal, what we will see? Low level of the sodium, normal level of the sodium, or the high level of the sodium. In more than 80% of the patient will see the normal level of the sodium. But what will happen in some patient? In some patient, you will see low level of the sodium. Low level of the sodium in blood. Why? Because aldosterone secretion is inhibited. And where you will see the sodium level? Sodium is going into urine. Mean that sodium will be going into urine in maximum concentration. Okay, guys, I already said about the word of osmolality. What is mean by the osmolality? This is very, very point. You have to understand this one, because this will help in the journey of entire medicine. Okay, guys, first of all, number 1, if any solution have high amount of the fluid or solvent and low amount of the solute, this type of the solution is known as the solution in which high amount of the fluid and low solute. This type of the solution is known as a hypotonic solution, number 1, or hypoosmolar solution. Okay, guys, mean that if a person have the hypotonic or the hypoosmolar solution, it's mean that the person have the low solute and high solvent. On the other hand, if any person present to you with low amount of the fluid in solution and high amount of a solute, this type of the solution is known as a hyperosmolar or hypertonic solution Okay, guys, now tell me what happened in case of SIADH. In case of SIADH, everyone who is listening me must understand that in a patient of SIADH, maximum fluid go into your blood. in blood, maximum fluid go. When maximum fluid will go into the blood, then the serum osmolality should be low or high? The serum osmolality should be low. And what is the normal serum osmolality? Guys, the normal serum osmolality is a 300 milliosmol, 290 to 300 milliosmol. What we'll see in this person? We will say low than 300 milliosmol. Why? Because we know that the maximum fluid is going into your blood and the fluid is not going into urine. When the fluid is not going into the urine, so this type of the fluid which will found into the urine, this is a hypotonic solution or the urine or the hyperosmolar urine. We will say this one is a hyperosmolar urine, and if someone have a hyperosmolar urine, it's mean that the normal osmolality of the urine is also equal to your blood, mean that 290 to 300 roundabout. We will say it will be more than 300, it will be round about 600 milliosmol of the urine, and the fluid is not going into the urine. When the fluid is not going into the urine, which type of the urine will be formed in the result? We will say the urine will be concentrated. Which type of the concentrated urine will be formed? Hope so you guys understood each and everything about SIADH till we discussed here. Now we will discuss about the causes. What are the causes, guys? Causes. We will say the main causes of SIADH is if examiner asks you a question, the most common cause of SIADH, you have to give the answer small cell lung carcinoma. Which one is a small cell lung carcinoma? Guys, why small cell lung carcinoma is causing the SIADH? We know ADH is going to produce from the hypothalamus. ADH in normal person produce from the brain, and here we are discussing that the lungs are going to produce antidiuretic hormone. When in normal person we know that antidiuretic hormone produced from where? Antidiuretic hormone produced from brain, okay? But if in person antidiuretic hormone is not producing from brain, antidiuretic his hormone is start to produce from somewhere else than brain, then this production is known as ectopic production. And in a patient of small cell lung carcinoma, what happened? In a patient of the small cell carcinoma, antidiuretic hormone basically produced from the lungs, not from the brain. When antidiuretic hormone will produce from the lungs, it means that this is an ectopic production, and the symptoms which all we will see in this patient. And after that, when we'll see a lot of symptoms, this can lead to the paraneoplastic syndrome even. Okay guys, so this is known as the ectopic production. This is the most common cause of SIADH. Other than that, which type of the causes? Any lung disease. Which type of any lung? Maybe COPD, maybe sarcoidosis. Just remember like lung disease, okay? Sarcoidosis, maybe pneumonia, okay guys? These are maybe tuberculosis, okay? Other than that, CNS injury, maybe any trauma like this. And if any person is using the drug like antipsychotic, antidepressant or NSAID, non-steroid anti-inflammatory drugs, antipsychotic drugs, antidepressant drugs, these drugs also can lead to the SIADH or huge level of the antidiuretic hormone release in this person. Now we'll discuss about the diagnosis. How we will diagnose in this person? It's very simple, very simple. If you understood each and everything from the start to now, it is very easy for you. First of all, for the diagnosis, you know that what will happen in a patient of the urine osmolality. What will happen to the urine osmolality? Guys, tell me. The urine will be concentrated or diluted? We have to give the answer. Urine should be concentrated because all the fluid is going into blood. When the urine is concentrated, so the osmolality should be low or high? Urine osmolality should be high. It is around about more than 600 milliosmol. Okay guys, more than 600 milliosmol. In some books written 600 milliosmol, and the serum osmolality will decrease or high. We know that with the help of antidiuretic hormone, maximum amount of the fluid is going to reabsorb and it is going into your blood. When the fluid is going into your blood, it means that the fluid can have maximum concentration of the fluid and low concentration is the solute. So this is a hypotonic or the hypoosmolar solution. Hypotonic or serum osmolality mean that will be low. Serum osmolality will be low. Will be lower than 300 milliosmol because the normal osmolality is a 300. It will be lower than serum 300. Other than that, if we check the level of the sodium in the blood, what will happen to the level of the sodium, guys? We know that with the level of the sodium is going to happen that it should be low, mean that maybe the level of the sodium will be 120, 135, or the 130, like this 130, 135. The level of the sodium will be low. But if we check the level of the sodium in urine, what will happen? The level of the sodium will be urine is more than 20, mean that sodium is going to excrete in maximum amount where into your urine. And in some examiner also ask a question like this, guys, that they will ask a question, if any patient present to you with complaint of lethargy, confusion, disorientation, seizure, and the person have the hypoosmolar, serum osmolarities are low and the urine osmolarities are high, what is your diagnosis? We have to give the answer. The diagnosis is SIADH, and all the brain related symptoms is due to low sodium level. All the brain related symptoms are due to low sodium level. I hope so you understand this one, because you know that low level of the sodium cause the confusion, cause the smallness, okay guys, can lead to the lethargy, other than that disorientation, and even seizures, low level of the sodium. Now we will discuss about the treatment, that how we will treat this patient. Guys, if any patient comes to us with the help of with complaint or the with diagnosed case of SIADH, how we will treat? First of all, we have to restrict the fluid. Because we know that maximum fluid is going where? Into the blood. And if we are not going to intake the fluid, it's not going to make a big deal, because we know that already fluid is present into the maximum concentration into our blood. So number one is the treatment is a restrict of a fluid. Best initial treatment. Okay guys, we'll say it is a best initial treatment. So if someone asks you that which one is the best initial treatment, we will say restrict fluid. Number two, we know in a patient of SIADH what we see? Hyponatremia. And if someone asks you how we will treat the patient of the hyponatremia, guys, we have to give the level of IV hypertonic saline. If the level is even less than 120 milliequivalent per liter, hypertonic saline we will give. One thing also remember in your mind, that if the level of the sodium is 120, and we know that normal level of the sodium is around about 140 to 145, and there is a gap of in between of the 120 to 140 to 145 is around about 20. And if someone ask to you that you will treat this patient slowly or very rapidly, you have to give the answer that for the normal value, for making the normal level of the sodium, we have to treat the patient very slowly. We can't treat the patient of the hyponatremia very rapidly. Why? Because it can lead to the osmotic demyelination syndrome or the central pontine syndrome. What's mean by the central pontine syndrome? Central pontine syndrome mean that in this person, if in a person there is a low level of the sodium, and we are going to treat this person with high amount of the sodium, then it can lead to the central pontine syndrome or the central osmotic demyelination syndrome. Other than that, if someone asks you that a person have severe SIADH, and how we will treat this patient, we will say we will give the ADH receptor antagonist drugs. And we should know that which type of the drugs are known as a ADH receptor antagonist drugs: tolvaptan plus conivaptan. And if someone have the chronic history of SIADH, maybe the person have the SIADH from the last 2 years, then which medication we will prescribe? We will prescribe, in this case, the medicine is known as dimeclocycline. Basically, it is an antibiotic. Dimeclocycline. So this was all about the SIADH. I will also give a read from the USMLE step to CK, so no one can remain confused. And now I will repeat some important points which you guys should understand. Number one, guys, important points. Number one, antidiuretic hormone release from where? Hypothalamus. Antidiuretic hormone produce where? We will say it is a hypothalamus. And store and release from where? Release plus store where? Posterior pituitary. Come from hypothalamus to posterior pituitary with the help of which protein? Carrier protein. And the name of the carrier protein is the hypophyseal carrier protein. Number 4, guys, we should know that antidiuretic hormone is the main hormone which maintain the serum osmolality. Serum osmolality, okay, serum osmolality. Okay, number 5, in a person, antidiuretic hormone act on the two sides. V1 receptor cause the total peripheral resistance will increase with the help of V1 receptor, cause the vasoconstriction or the vasopression. So the other name of antidiuretic hormone is a vasopressive hormone. Number 6, V2 receptors aquaporin channels will be open and water will be reabsorbed. So maximum fluid will go where? Into the blood. Hypervolemia will see in this person. Okay guys, now we will discuss about SIADH, most important point. SIADH. Number 1, what will happen into patient of the SIADH? Serum osmolality will be low. It will be hypotonic or hypoosmolar serum. Number 1. Urine osmolality will be high. It will be concentrated urine. We will see a euvolemic hyponatremia. Why we see a euvolemic hyponatremia? Because of ANP and BNP is going to release. Other than that, aldosterone will be inhibited, and it can lead to hyponatremia. Sodium, where it will go? Into the blood or urine? Sodium will go into urine in maximum concentration. Sodium will be low into your blood. Okay guys, and how we will treat the level of the sodium? We will treat the level of sodium with hypertonic saline. And if we treat the patient of the hyponatremia very rapidly, it can lead to the osmotic demyelination. Very important point. Never ever forget these points. Okay guys, number 11. Other than that, osmotic demyelination, lethargy, confusion, coma, death, seizure, all these happen due to hyponatremia. Okay guys, next point. How we will diagnose this patient? The serum osmolality will be low, less than 300. Urine osmolality will be more than 600 milliosmol. Okay. Other than that, sodium, where it will go? Into urine more than 20. Okay. And how we will treat this patient? First line, best initial treatment is a fluid restriction. Fluid restriction is the best treatment. Number 2, we will say, if a person he has a persistent symptoms of hyponatremia, mean confusion, lethargy like this, we will do the hypertonic normal saline. And if a patient have the severe SIADH, how we will treat? Severe SIADH will be treated with the help of tolvaptan, conivaptan, ADH receptor antagonist. And if someone have the chronic SIADH, how we will treat? With the help of dimeclocycline. Hope so you guys understand. Okay, these all are the most important point. Never ever forget these points. Okay guys, now I will give read from the USMLE step to CK. Okay. In just 1 minute guys. USMLE step to CK, there is a compressed form. Like here, syndrome of inappropriate antidiuretic hormone is a common cause of euvolemic hyponatremia. I already explained each and everything in full detail about the euvolemic hyponatremia. Result from persistent ADH release independent of serum osmolality. Okay, next, may be associated with CNS disease. I have discussed about the brain injury, pulmonary diseases. I have discussed about the sarcoidosis, COPD, pneumonia, ectopic production, most common cause paraneoplastic syndrome. I have discussed about what is mean by the ectopic production and paraneoplastic syndrome, small cell lung carcinoma, most common cause, and some drugs. Okay guys, and how we will diagnose this one? Serum osmolality will be low and urine osmolality will be high. This is very important. Here is not written true. Okay, urinary sodium level will be more than 20 milliequivalent per liter. Explore and address the underlying cause. Mean that we have to find that what is the main causative agent of SIADH, and we have to treat that one. Best initial treatment: restrict the fluid. Persistent the symptomatic hyponatremia. If the person have the less than 120 milligram, we will give the IV hypertonic saline. If a person has the severe SIADH, ADH receptor antagonist, tolvaptan, conivaptan, chronic SIADH, dimeclocycline macrocycline. Okay, and here guys, fluid restriction is the cornerstone of SIADH treatment. Correct hyponatremia slowly to prevent osmotic demyelination are the central pontine syndrome, same thing. Okay guys, and I hope so everything is clear for you. And now we will discuss about the one of the most important topic, diabetes insipidus. Then what will happen for the diabetes insipidus? Okay guys, for diabetes insipidus, it is a condition in which the antidiuretic hormone is not going to produce, or antidiuretic hormone is not going to work properly on the kidney. Mean that diabetes insipidus, it is a condition. Diabetes insipidus, it is a condition in which we will see two type of the things. One, either there is a problem with the brain, whether is a problem with the brain or the problem with the kidney. If a person have the problem with the brain, and we know that in a normal person antidiuretic hormone basically produced from where? From the brain. And if a person have the problem with the brain, antidiuretic hormone will not produce. If antidiuretic hormone is not going to produce, this type of the diabetes insipidus is known as a central diabetes insipidus. Okay, and if a person have a normal or high amount of the antidiuretic hormone, but the problem with the V2 receptors mutation, guys, we know that antidiuretic hormone come and act attached to the V2 receptors and cause the activations and opening of the aquaporin channels. But when there is a problem with the V2 receptors, how much antidiuretic hormone is present? It's not going to affect on the V2 receptors because it is already muted. Then what is going to happen? Mean that water is not going to reabsorb from your kidney tubules and it will not go into the blood. Okay, and if the problem with the kidney, and you will see the diabetes insipidus. So this type of the diabetes insipidus is known as a nephrogenic diabetes insipidus, guys. Okay, I hope so you guys understand about the diabetes insipidus, that which type of the diabetes insipidus is known as a central diabetes insipidus and which type of the diabetes insipidus is known as a nephrogenic diabetes insipidus. Okay guys, now we will discuss little bit more in detail about the diabetes insipidus. First of all, we have to understand that what are the causes of the central diabetes insipidus. Central diabetes insipidus, what are the causes? So basically the central diabetes insipidus, we will say that the main causes are that maybe the problem with the posterior pituitary, mean that we know that the posterior pituitary is the main side from where the antidiuretic hormone is produced. So maybe the problem with the posterior pituitary. Okay guys, number one, maybe trauma. Number one. Number two, you have to give the answer, maybe trauma, maybe any ischemic cause. Okay, maybe postpartum hemorrhage. And Sheehan syndrome, we will say Sheehan syndrome or the postpartum hemorrhage. Don't worry, we will discuss this Sheehan syndrome in full detail into the gynecology and also into hypopituitarism. It's not going to worry. Okay, we will discuss in full detail what's mean by the Sheehan syndrome. And other than that, what is going to, we will say there may be traumatic brain injury, maybe there is attack on the brain, infection. Okay, infection, any autoimmune diseases. There are a lot of causes can lead to the central diabetes insipidus, and there's no need to worry because examiner don't ask about that what are the causes of the central diabetes insipidus. Examiner ask some other question we will discuss now. Okay guys, and now we will discuss about the causes of the nephrogenic diabetes insipidus. These are the most important than the central diabetes insipidus causes. Okay, nephrogenic diabetes insipidus causes. Hypercalcemia, high level of the calcium basically effect on the kidney and cause to not give the proper response of the V2 receptors. Okay guys, hypercalcemia, low level of the potassium. Number three, we will say that nephrogenic diabetes insipidus, if any type of the person is using a drug like antibiotic from a long period of the time, maybe from the 2 months, 3 months, demaclocycline, and we know that demaclocycline is a V2 receptor, ADH receptor antagonist. ADH receptor antagonist. Maybe the person is using demaclocycline or tolvaptan, conivaptan. These are also ADH receptor antagonist. So if the person is using these drugs, tolvaptan, conivaptan, demaclocycline, then what is going to happen? ADH will come and it will not going to act on the V2 receptor because these drugs basically cause the inhibition of these drugs basically cause the inhibition of antidiuretic hormone. Antidiuretic hormone will not work on the V2 receptors. Okay guys, now other than that, we have to understand the lithium. lithium also can lead to nephrogenic diabetes insipidus. Okay, this was all about the nephrogenic diabetes insipidus, central diabetes insipidus, causes. Now we will discuss little bit in more detail about the diabetes insipidus, that what is going to happen in a patient with the diabetes insipidus. Everyone who's listening me must know now about the mechanism of antidiuretic hormone in a full detail. We know that antidiuretic hormone, basically what they do, just take an example that this is a collecting tubule. I'm just mentioned that this is a collecting tubule. Okay, if this is a collecting tubules and these are the your principal cells, and in normal person what happen, in normal person antidiuretic hormone basically come and act on the principal cells V2 receptors. Now just take an example, if antidiuretic hormone is not coming here, number one case central diabetes insipidus. If antidiuretic hormone is coming here but the problem with the V2 receptors, V2 receptors are not giving to the response to the antidiuretic hormone, nephrogenic diabetes insipidus. We know that in a normal person antidiuretic hormone come on the V2 receptor, cause the opening of the aquaporin channels, and fluid will, where it will go, fluid reabsorbed from the kidney tubules and it will go into your blood vessels. Okay, blood vessels. But when the antidiuretic hormone is inhibited or antidiuretic hormone is not going to produce, then all the fluid will not go into the blood. This all fluid will go into urine. So what we will say, diluted urine mean that in the urine what will be the present, maximum of the fluid, low amount of the solute. Now guys, you tell me about that, if any solution have the maximum of the fluid and low solute, what is the name of this solution? Is a hypotonic solution, and what we'll see in this person will do the complaint of the polyuria, that this patient have the complaint of the polyuria, also the diluted urine, also the person have the high amount of the fluid and low amount of the solutes. So that's why we'll say that this condition is known as a polyuria. Okay guys, when the fluid is going where? The fluid is going in the maximum amount into the urine. So it's mean that into the blood there should be the low amount of the sodium. Okay, and it can lead to the hypernatremia. In normal person there is not hypernatremia. We'll see in some patient will see the normal level of sodium. Even in many patients what we will see, normal level of sodium, but in some patient what we will see, high level of the sodium. Why high level of the sodium? Because we are losing a huge amount of the fluid. Okay, when we are losing huge amount of the fluid, where the huge amount of the fluid we are losing into the urine, and less amount of the fluid, where it is going, less amount of the fluid is going into your blood. Guys, what we'll see in a patient of diabetes insipidus, maximum of the fluid, where it will go, into the urine. When maximum fluid will go into the urine, this type of the fluid is known as the solution is known as a hypotonic or hyposmolar solution. Hypotonic or hyposmolar solution, guys. Okay, number one. Number two, when the fluid is going into the urine, mean that the fluid is not going into the blood. When the fluid will not go into the blood, okay, when the fluid is not going into the blood, so what we will see into the serum? In the serum, the fluid will be low. Sodium concentration, now it will be high because solute is a high. Okay, so this type of the solution is known as a hypertonic solution, hyperosmolar or hypertonic solution. Okay, it's not a big deal that what is a hyperosmolar or hypertonic, you can see it both. Okay, hypertonic solution. So when there is a high amount of the sodium, then what is going to happen? This high amount of the sodium cause the activation of the thirst center will be active. When the thirst center will be the active, it can lead to the what? Polydipsia. So in a patient of diabetes insipidus, what you guys will see? Polydipsia and polyuria. Many persons tell just polydipsia, polyuria. They don't know about the mechanism, that how we see the polydipsia in a patient of SIADH. Diabetes insipidus. At least we have to tell the mechanism now, because if a person know that what is the mechanism of polydipsia, then we will understand the normal mechanism, abnormal mechanism, then we can become a good doctor. And here what is mean by the polydipsia? Because when there is a high level of the sodium, it basically causes the activation of your thirst center. When the thirst center will be active, the person will feel the thirst, and after that the person will do the complaint of the polydipsia and polyuria, two complaints. Okay, other than that, guys, what we will see? We will see due to the high level of the sodium, what happened? High level of the sodium and low level of the sodium both can lead to the same type of the symptoms. Mean that In the low level of the sodium, what we have seen, we have discussed that low level of sodium can lead to the lethargy. Yes, here we will also see. We also discuss seizures. Yes, here we also discuss coma and mental status abnormal. We also discuss all these things. Four things also we can see into hyponatremia and hypernatremia. Now, how we will diagnose the patient of diabetes insipidus? Diagnose. Okay, guys. First of all, take the example that in a person in which antidiuretic hormone is not going to produce, what will happen to the serum osmolality? We know that serum osmolality will be high because of a high concentration of the solute and low concentration of solvent as compared to your urine osmolality. Yes, urine osmolality will be low. Urine will be concentrated urine. Yes. Other than that, we will perform a very important test. Which test? We will also see the urine sodium level. We know that here the sodium will go into the urine or it will remain into blood. Guys, it will remain into the blood. It will not go into the urine. So urine sodium level will be low, but in the blood sodium level will be maybe normal or also can see high. Okay guys, hope so you understand. I also have discussed in full detail that why we see hypernatremia in a patient of diabetes insipidus. Number 3, the most important test. Just take an example that this person is IA. This person couldn't drink even a single drop of water. If this person couldn't drink a single drop of the water, so in normal person what will happen? And this person go into the restroom. When the person will go into the restroom and when the person do the urine, what we will see? Which type of the urine we will see? Concentrated urine. Yes, concentrated urine. But if in the water deprivation test, we say to the patient, don't drink the water, and after that we take the sample of the urine of the patient. When we will say the sample of the urine of the patient, we see that there is not a concentrated, there is a diluted urine. There is a diluted urine. Okay, mean that even the person couldn't drink a single drop of the water, but the urine is a diluted, and there is a maximum solvent. Maximum is a fluid. So this type of the solution is known as a hypotonic. Mean that if person couldn't drink even a single drop of the fluid, the urine is a diluted, the hypotonic solution. So it's mean that antidiuretic hormone is not working even a single %. So this type of the patient is known as a diabetes insipidus. Our diagnosis is confirmed. Now we have to understand that this type of the diabetes insipidus is a central or nephrogenic. Now we have to discuss that which type of this type of the diabetes insipidus, either this is a central or this is a nephrogenic. Okay, now central or nephrogenic. Okay guys, how the examiner ask you a question? Examiner will ask you a question that a 35-year-old male present to you with complaint of the polyuria and polydipsia, and upon investigation the urine osmolality is a 150 milliosmol, mean that low, and the serum osmolality is a 450 milliosmol, mean that the serum osmolality is a high. Okay, what is your diagnosis? We will say it is a diabetes insipidus. Okay, other than that, examiner more than that ask a question like this: that a 35-year-old male present to you with complaint of the polyuria and polydipsia, the urine osmolality is 150 milliosmol and the serum osmolality is a 450 milliosmol. After injecting the desmopressin or after giving the desmopressin, the serum osmolality and urine osmolality totally changed. Which type of the diabetes insipidus? If the osmolality changed, if urine output decrease, it's mean that this type of the diabetes insipidus is a central diabetes insipidus. Okay guys, now for example, the problem with the central mean that the person antidiuretic hormone is not going to produce. Okay, we will give the antidiuretic hormone to differentiate between either the problem with the brain or the kidney. When we will give the antidiuretic hormone, the other name of the antidiuretic hormone guys is a desmopressin. When we will give the desmopressin, after giving the desmopressin, we know that what is going to happen if the brain, the problem with the brain in a normal in this person, in this patient, antidiuretic hormone was not going to produce. But what we did, we gave the antidiuretic hormone from outside of the body in the form of medicine. When we have given the antidiuretic hormone in the form of the medicine, so what the antidiuretic hormone will do here, this antidiuretic hormone will do, it will come into the collecting tubules, it will act on the V2 receptors. Here's not problem with the V2 receptors. Okay guys, it opening the aquaporin channels. Aquaporin channels will be the open. When the aquaporin channels will be the open, the fluid will, where it will go, the fluid will go into blood. When the fluid will go into the blood, so the urine concentration, so the urine output will be low. Number one, urine output will be low, so the fluid will come into the urine. No, when the fluid will not come into the urine, so before giving the medication, the urine osmolality was low, but now the solvent or the fluid is not going to come here, only the fluid are coming here. So this solution is going to become hyperosmolar solution. Mean the osmolality change? Yes. And before giving the desmopressin, the serum osmolality was very high, hyperosmolar solution. But when we have given the antidiuretic hormone, this basically causes the reabsorption of the fluid from the kidney tubules, and the fluid is going to come into the blood. When the fluid is coming into the blood, it can lead to the hypoosmolar solution, mean that the serum osmolality will be low. What happened? Urine and serum osmolality both change, urine output decrease. If examiner asks you a question that after giving the desmopressin, urine and serum osmolality change, urine output decrease, which type of the diabetes insipidus this one? We will say this is a central diabetes insipidus. Okay guys, if a person have the problem with the V2 receptor mutation, in that person antidiuretic hormone is already normal or high. Okay, when antidiuretic hormone is already high and we will give the antidiuretic hormone more, it is going to work? No, it is not going to work. We will say if we have given the antidiuretic hormone or the desmopressin in the form of the medicine and serum osmolality didn't change, so this type of the diabetes insipidus is known as a nephrogenic diabetes insipidus. I hope so you guys understand about this one. Now we'll discuss about the treatment, that how we'll treat this patient. Okay guys, the central diabetes insipidus, what we will give? Desmopressin, simple, from the outside of your body. And if a person have the nephrogenic diabetes insipidus, first of all, in a case of the nephrogenic diabetes insipidus, we know that in a patient of the diabetes insipidus we see the hypernatremia, mean that we see the high level of the sodium. So first our work is to low level of the sodium. We will recommend that you have to salt restriction. We will do the salt restriction, number one. Number two, reduce water intake. Reduce in water intake, because person is going to already have the complaint of the polyuria, polydipsia. Reduce water intake. Number third, hydrochlorothiazide. We'll give the diuretics, and the name of the diuretic hydrochlorothiazide. Okay guys, and number four is the amiloride. These are the drugs which we prescribe in a patient of the diabetes insipidus. What are the most important points in the diabetes insipidus? In the diabetes insipidus, number one, in this person what we'll see? High serum osmolality, low urine osmolality. No, very important point. Okay, what we'll see? High level of the sodium, low sodium will go into urine, but high level will be sodium into your blood. Hypernatremia. This hypernatremia basically causes the polydipsia. I have discussed already how the polydipsia. If the person have the low level of the antidiuretic hormone production, central diabetes insipidus. If the person have the normal or the high antidiuretic hormone, the problem with the kidney, nephrogenic diabetes insipidus. Okay, mean the normal level of the antidiuretic hormone, but the person still have the diabetes insipidus, nephrogenic diabetes insipidus. If the person have the problem with the brain, a lot of causes, but we have to discuss here the most important things related to your kidney, mean that hypercalcemia can cause nephrogenic diabetes insipidus, hypokalemia can cause to the nephrogenic diabetes insipidus. Lithium, very important guys, very important. Lithium, dimethylcycline, tolvaptan, conivaptan. Okay, these all can lead to the nephrogenic diabetes insipidus. So these all are very important things about the nephrogenic diabetes insipidus and central diabetes insipidus. Other than that, we'll give the desmopressin. After giving the desmopressin, if the serum osmolality change, it means that the person was the central diabetes insipidus. If doesn't change, it means the nephrogenic diabetes insipidus. The main test is a fluid. You have to give the water deprivation test. Water deprivation test, after doing the water deprivation test, if a person have still diluted urine, mean that the person have the diabetes insipidus. Okay guys, person have the diabetes insipidus. Treatment, For the central, we will give the desmopressin, and for the nephrogenic, what we will do, nephrogenic diabetes insipidus, we will give the hydrochlorothiazide, salt restrictions, and amiloride. Okay guys, now we will give a read from the USMLE step to CK. If you guys have a problem that I just go through the USMLE step to CK, you also can mail me on dr.zdbi776 @gmail.com, because I will receive your mail and I will able to give the answer on the mail. Okay guys, and that how are you feeling my method of the teaching? Diabetes insipidus, as you have know that what is going to happen here, the diabetes insipidus, here is the central diabetes insipidus, the posterior pituitary fail to secrete, yes, tumor, ischemia, maybe the metastatic causes or the autoimmune diseases. Nephrogenic, there's a problem with the kidney to fail to circulating the ADH, causes include renal diseases, drug lithium, demeclocycline, tolvaptan, conivaptan also right here. Other than that, present with the polydipsia, polyuria, and persistent thirst, diluted urine, normonatremia. In most cases, what we'll see, normonatremia. In some cases, we'll see hypernatremia. Okay, if access to water is limited, and patients may present with dehydration, severe hypernatremia, leading to altered mental state, lethargy, seizure, and coma. I have discussed that hypernatremia and hyponatremia patients have same symptoms. Lab test. We have discussed already that there will be the serum osmolality will be the high, urine osmolality, urinary sodium will be low. I have discussed each and everything in full detail, and possibly hypernatremia I also have discussed. Water deprivation test is the first one. Even after performing the water deprivation test, the person of diluted urine. This one is in diluted urine. Desmopressin we will give test if central diabetes insipidus, if the urine output decrease and urine osmolality is high. After giving the desmopressin, is mean the central diabetes insipidus. If no change, no effect, nephrogenic diabetes insipidus. MRI can perform for seeing that there is a problem with the brain. Treatment, underlying cause and central, we will give the desmopressin. For the nephrogenic, will the salt restriction, water intake will reduce, and hydrochlorothiazide and amiloride. So this was all about the diabetes insipidus and syndrome, inappropriate antidiuretic hormone. So guys, if you have any type of the question, you can mail me on my email dr.sabi776 @gmail.com. Why I am mentioning my mail here, the main problem is this, that if you guys have a question, I will be able to give the answer to you guys. Okay, and